Welcome, everyone, and thank you for joining us for the fifth webinar of our Carousel Care campaign, a national advocacy campaign that's focused on NICU family support and well-being. I am Ashley Osbourne, a neonatology fellow at the Children's Hospital of Philadelphia, and my co-moderator is Heather Ousley, a social worker also from the CHOP NICU. Today, our webinar is going to focus on parental mental health screening and next steps in the NICU. The first three webinars of the campaign focused on parental support before birth, and last month's webinar was the first of our second series of three webinars that are focusing on important themes that arise during the time of the NICU admission. The last portion of our advocacy campaign will focus on life after the NICU. Next slide. I'd like to acknowledge our amazing planning team that made this webinar happen. Again, Heather Ousley is my co-moderator today. Dr. Christine Pazandak and Dr. Michelle Spencer are the directors for this section, which again includes three webinars focusing on how we can improve parental support during the NICU stay. And Dr. Katie Hogue is our TECaN Advocacy Campaign Chair, and she and Dr. Ann Blake are our TECaN Advocacy Vice Chairs. And Dr. Allie Sloan is our TECaN Advocacy Chair. All these wonderful people help make this webinar series happen. Next slide. We are very excited to offer CME credit through UT Southwestern. So after today's webinar, you will receive a survey that will help us better gauge who we are reaching in our content, assess the knowledge gained, and know how we can continuously improve this webinar series. As a reminder, today's session is being recorded, and the recording will be available after the webinar is completed on our campaign's website. The link is going to be added into the chat box, or it can easily be found if you Google TECaN Advocacy. Feel free to share this webinar and our website with friends and colleagues. And thank you all for being here today. We are looking forward to a great session.
We'd like to take a moment to acknowledge that while we traditionally talk about the NICU interventions for moms and dads, we know that families are built in a variety of ways. We strive to use inclusive language in our discussion throughout today. Addressing mental health in the NICU. Next slide, please. Approximately 9% of women experience postpartum post-traumatic stress disorder following childbirth. 15 to 53% of women whose children are in the NICU experience postpartum post-traumatic stress disorder. Next slide, please. Up to 1 in 5 women will suffer from maternal mental health disorder like postpartum depression. And it's not just moms. Maternal mental health disorder impacts the whole family, not just women. One case that I'll never forget is when we had a mom in our NICU who was hospitalized with postpartum psychosis shortly after her daughter was admitted. Mom received one of our screeners, and between that, our social work assessment, we were able to identify her and dad's mental health history, treatment, and current supports. Between myself and our psychologist, we were able to help get the parents the resources they needed to help support mom through her psychosis, dad's mental health, as well as support them through their daughter's hospitalization. This is just one little example about why we need to continue to address mental health in the NICU. Next slide, please. It is my pleasure to introduce today Dr. Stephen Lassen. Dr. Stephen Lassen is a professor of pediatrics and psychiatry and behavioral sciences at the University of Kansas Medical Center. He received his PhD in clinical child psychology from the University of Kansas. He completed his residency in clinical child psychology, pediatric psychology at Harvard Medical School, and postdoctoral fellowship in pediatric psychology at the University of Washington School of Medicine. Dr. Lassen's clinical and research interests include perinatal mental health, children with chronic or life-limiting illnesses and their families, as well as the impact of parental illness on children. Dr. Lassen serves in leadership roles in various mental health and medical organizations and lectures regularly to regional and national audiences on a variety of mental health issues. Welcome, Dr. Lassen.
Thank you very much. So good to be with all of you. I was enjoying kind of scrolling through to see who is on the call today, on the presentation today, and so pleased to see so many good friends and people I've worked with over the years. So very glad to be here. I wish we could be in person, but maybe in the future that will happen. So I've been working in the NICU for about 14 years now, and really pleased to be able to come today and be invited by this great initiative and great group of leaders to talk about psychosocial screening parents in the NICU. And excited to share some of the things that I've learned over time. And I hope that this is a real practical discussion today, and you'll leave with some ideas for how to begin screening efforts in your particular units and hospitals, or perhaps improve the efforts that you have already initiated. So these are our objectives today, really to identify some best practices in establishing psychosocial screening protocols in the NICU, recognize and appreciate some of the barriers to doing so. And then I'd like to end with a discussion about how I think we can use technology and a better way to screen and to treat mental health issues in the NICU. So why talk about screening in the NICU? Well, we're not going to go into all of the numbers. You all are familiar with those, but suffice it to say, the NICU is a stressful experience for parents. And part of that stress is seen in the consistent high levels of mental health symptoms that are reported by parents. And so we have a duty to address those. We have a duty to screen for those and do something to relieve some of that burden on the families. Not only do we have, I think, a moral and professional duty to do that, but we know that parental health is crucial to child outcomes. So we need healthy parents in order to have the best child outcomes that we can. So screening is one way, one pathway to do that. And then lastly, I think, the rationale for having this discussion today is that there are certainly limited psychosocial resources in the NICU. Hopefully each of you have some of those, but I know some of you do not. And so we need to be able to allocate those effectively. And one of the ways that we do that is by screening effectively, so we know who needs what and when. So one of the ways I think we can conceptualize screening in the NICU is with this model, the Pediatric Psychosocial Preventative Health Model, that was originally developed by Ann Kazak and her colleagues in the early 2000s. And this is really a biopsychosocial framework for assessing and treating families who have children in a pediatric health setting. So I think it fits very well with the work that we do in the NICU. And if you think about this triangle as representing the whole of your NICU parent population, you'll see that the bottom tier represents most NICU parents who are stressed but adaptive and doing fairly well. The middle tier would represent parents who are experiencing increased distress and have some psychosocial risk factors for worsening symptoms. And then the top tier represents parents with the most psychosocial needs and are the fewest in number, fortunately. So as you move up this triangle, the needs certainly increase, but the numbers of parents that we're working with decrease as well. So at the very top of the triangle, we have the fewest number of parents, but with the highest amount of need. And then resources are additive as you move up the three tiers. So this is not unlike stepped collaborative care models like Wayne Caton at the University of Washington has developed, where we treat patients with adequate treatment, but at the lowest possible intensity while we continuously monitor progress. So screening in the NICU should ultimately and hopefully identify parents in terms of these tiers, which would then be associated with appropriate levels of interventions. So some of the goals that we have when we're thinking about screening parents in the NICU, one would certainly be to identify psychosocial difficulties in parents with babies in the NICU. Also to allocate limited psychosocial resources effectively and efficiently. We don't have an unlimited supply of these, and so we need to learn to allocate them, I think, better. Normalizing psychosocial needs of families in the NICU. This is sometimes not as well appreciated as I think it needs to be, but as we screen these families, then one of the things that we're doing is normalizing the psychosocial needs that they have, especially as we do so in a universal way. And then lastly, think of psychosocial screening really as an intervention, and an intervention that can ameliorate psychosocial risk and mental health symptoms of parents in the NICU. As we screen, parents feel supported, and we open a dialogue with them about mental health. And we also have good research to suggest that just by asking about these things, they tend to get better, because it does open up this dialogue, but it also increases awareness and changes behavior. So we're not only screening, but we're intervening in really important ways too. So I'm going to be using this term psychosocial instead of mental health today to really speak to some of the broader challenges that parents face during the perinatal period, and specifically in the NICU. When we think about psychosocial risk factors, that certainly includes mental health symptoms, but it's broader to include, I think, a lot of other factors that enter into the overall functioning of parents in the NICU. So just a bit of a rationale for why I'm using that term today. So there's been a lot of work done in this area in the past few years. These are just a few of the more recent published reports of descriptions of the development and implementation of screening protocols in the NICU setting. And this is what I'm going to really use to draw from today. I'm not going to talk about necessarily just my experience here at KU with screening, but I'd really like to draw from all of these great articles and summarize best practices as we have them today. And so you'll see just a combination of suggestions that are derived from each of these articles. So as we think about developing a screening process, we're going to kind of go through what that process would look like, what questions we need to ask, and some of the things that would guide our thinking around it. I think we need to consider conducting initial staff education before we implement any screening protocol. We need as many champions as we can get when we're developing an initiative like this, and we need some investment from the team. And so there's a real danger, I think, in moving too far ahead of the staff and not including them in the development and the educational piece before we start to implement. And so make sure that you've got some buy-in. This is where you have to be a salesperson. You have to really sell your product before you can move forward implementing. So we need to be thinking about what to screen for. We can't screen for everything, and we need to focus our efforts and resources really on the most common types of psychosocial problems. So we know that the big three areas in terms of mental health concerns in parents would be depressive disorders, anxiety disorders, and trauma-related disorders. But again, we need to understand too the more broad psychosocial risk factors that parents are faced with. These include a whole host of demographic factors, family functioning factors, concurrent stressors, trauma perceptions, and social support. Each of these exert an influence on mental health and overall functioning in the NICU. And so I'm going to continue to advocate that we do a better job of screening for these and intervening in these different areas. You've seen it as well as I have. We frequently have parents who are struggling with transportation, with a lack of social support, and that's highly correlated with their emotional well-being. And so we can't neglect those factors as we're screening. So how do we go about screening? There are a number of different modalities that we can think about. First and foremost, we need to be using validated measures, which just means that this is a measure that is measuring what it's designed to measure. It's been through some research and some some testing to validate it. And so make sure that what you are using is a valid measure. Sometimes we come across folks who are developing their own measures and developing their own questions to ask parents. And there's certainly a validity to that. And we need to continue to develop additional measures, but just be aware that if we're not using existing validated measures, then I think we're doing our families a disservice because we're just not sure we're measuring what we think we are. And all the measures that we'll go over today have been through that process. We need to consider whether we're going to use a technological platform versus paper assessments to screen. Things like REDCap platforms and other electronic platforms are being used increasingly to do this, which I think is a good thing, where information is then taken to the electronic medical record. But I think we have additional resources at our fingertips for that, which we'll talk about later. Paper assessments tend to be the standard traditional method that we still do this with, but there are some drawbacks to that. Are we going to conduct these screenings on the phone or in person? These are just some questions that need to be asked ahead of time. As far as I know, we don't have any research really looking at the differences in screening modalities. So that would be important work to do in the future to understand which gives us more accurate data. So let me list through just a few of the depression measures that can be used for your information. We're all familiar with the Edinburgh Postnatal Depression Scale. It's a 10-item self-report with a score of 10 or greater, yielding a score suggestive of postpartum depression, or a yes to just question 10, which is about any urges to self-harm. There is a 3-item version of the EPDS with good psychometric properties. If any of you are overwhelmed by the 10 items, you can shift over to the 3-item version. It's free, translated into a lot of languages, very user-friendly, face valid. It's a good measure. It does not have some of the neurovegetative symptoms that for depression that it could have. So that's one of the drawbacks, I think, of this particular measure. Postpartum depression screening scale. It's a little longer, self-report measure, does require some training for the administration and interpretation of it. It's commercially available, so it costs a little money. It's available in Spanish and Italian, but also because it's commercially available, it does have the option to be administered and scored electronically, which can be nice. And let me just add a couple of caveats before I get too further. None of these measures are normed on NICU parents. So some of them have been normed on postpartum, perinatal populations, but none of them have been normed specifically on NICU parents. I don't think that's a deal breaker here for any of these, but just be aware that these are measures that we're using in the NICU that have been normed on different populations. None of these measures are diagnostic either. That's an important thing to keep in mind. These are screening measures, they're not diagnostic measures. So in order to get to that level of diagnostic clarity, we would need to do additional assessment. Okay, some other depression measures. The PHQ-9 is a really good measure. It's short. It also includes a suicidality item, which I think is really, really important. It's also free and available in Spanish. The Beck Depression Inventory, another commercially available measure, has been studied in postpartum women populations and behaves fairly well in that population. There does seem to be a higher rate of false positives among postpartum women, but generally does a good job at screening for depression. Okay, some anxiety measures. The General Anxiety Disorder 7 scale. It's a short self-report, free, translated into multiple languages. Does a pretty good job of screening for anxiety. Another Beck measure, the Anxiety Inventory. Again, commercially available, which brings with it some benefits, but there is a cost associated to that. And then maybe less well known is the Edinburgh Postnatal Depression Scale, which is actually for anxiety. It's a 3-item subscale of the EPDS, items 3, 4, and 5, that actually do a really good job of screening for anxiety. So if you're going to use the EPDS, you should really be looking at those items 3, 4, and 5 as an additional anxiety screener as well. Okay, and then just some trauma measures here. The perinatal PTSD questionnaire. I noticed Dr. Heinen is on the call today and has done just a fabulous job with this measure. It's a great screening measure. It's short, translated into several other languages, and does a very nice job of screening for PTSD symptomatology. A newcomer to the trauma measure family is the City Birth Trauma Scale. This was normed on postpartum women, so there's an advantage to that. It was also normed based on DSM-5 diagnostic criteria. So those of you unfamiliar with the DSM-5, that's the most current diagnostic manual that we have. And the diagnostic criteria for PTSD changed quite a bit in this new version of the manual. And so the fact that we've got a screening measure that is consistent with that, I think, is really helpful. And it's free for use. The Impact of Events Scale is one that's commonly used, which is another very good measure. It's free, translated into several different languages. And then lastly, the PCL-5 is a 20-item self-report, again, translated into several other languages, and it's free to use. Let me just make a comment about these measures before we move on, and that is that most of these are going to ask the participant to think of a particular trauma event to respond to the items of the scale. And so this can be problematic for a couple of different reasons. First of all, for parents who have experienced multiple traumatic events over the course of their life, it can be really difficult to focus on just one of those. And sometimes we try to have people focus on the one that seems to be most salient at the moment, or the one most relevant. But even then, it can be really hard to distinguish for a lot of families between, this traumatic event versus that traumatic event. So that's a downside to these measures. And so the other thing that we want to be careful about is not encouraging them to emphasize one traumatic event over another. And sometimes we can do that. If we're asking in the NICU, we can inadvertently bias them towards reporting on NICU-related trauma versus others that they may have had previously. So it can be a little tricky to administer these and to field some of those questions that they have. I just had a mom the other day that I went through this process with, and she had about a dozen different traumatic events that she listed out. And she really couldn't differentiate between them sufficiently to pick one out to report on. And so I decided it probably wasn't a good idea to pursue that. And we did some screening verbally back and forth. And I was able to ask her some specific questions to get at her trauma symptomatology at the time. But it's just a downside to these trauma measures. Okay, so in terms of measuring psychosocial risk, there is one tool that I'd like to just familiarize you all with that is new as well. This is a tool that we began adapting and working on years ago, which has come a long way, and I'm proud to say that we've got the validation process completed. So Dr. Amy Bauckham at Nationwide has done a fabulous job with her team in validating this measure that really looks at broader psychosocial risk. It's an adaptation of Ann Kazak's psychosocial assessment tool, which was originally developed to assess psychosocial risk in families where children had just been diagnosed with cancer. So we've adapted this for the NICU, and I think it does a great job of measuring and assessing broad psychosocial risk, but also mental health symptoms more specifically. So these are the 6 subscales that the PAT NICU measures: family structure and resources, social support, sibling problems, family problems, stress reactions, and family beliefs. And so I think the benefit of a tool like this is, again, it takes into account a lot of different risk categories, not just diagnostic categories, and it allows for risk categorization all in one measure. So before we had the PAT NICU, in order to get all of this information, you'd really have to administer a handful of measures, which can be more problematic and more frustrating for families. And so, again, look for this to be available in the next little bit, I think, as the development continues on. There's an overall risk score that's calculated for the PAT NICU, and then that risk score is categorized into one of those 3 PPP-HM risk tiers that we looked at before. And so that allows us to look at psychosocial risk in terms of different resources that might be available to families. So when do we need to screen? That's a question that often comes up. What time frame is the best to do this in? Well, from all the published data and certainly from my experience, 1 to 2 weeks after NICU admission seems to be a good time frame to do this in, and then prior to discharge as well, to get another snapshot of where parents are and what they might need as they move post NICU. But really also we need to think about all of those families that come and go in the NICU prior to that 1 or 2 week window. We have a lot of babies that just don't stay in the NICU 1 to 2 weeks, and we need a process for more informally screening them. I think typically it can happen as part of the social work intake interview, but sometimes not. So we need to think about how to screen those families. And then we need to think about just ongoing assessments. I think we do families a disservice if we just think about screening at the beginning of admission and prior to discharge. There's a lot going on in the life of a family in the NICU from admission to discharge. There's a lot of psychosocial change going on, a lot of changing landscape in terms of the baby's condition and the parent's adaptation to the NICU itself. And so we need to be able to capture that and again, offer families what they need based on that screening and assessment. One of the ways that we've addressed that here at KU is, for many years now, I have spent a lot of time with our staff trying to increase their capacity to do some of this ongoing screening and assessment themselves. I'm only one person. I'm the only psychologist here. And that's just really limits the amount of work that I can do. And so I've really tried to educate and create greater capacity within our staff to do some of this. And so we've done training in nonverbal assessments, nonverbal communication, signs and symptoms of depression, anxiety, and trauma disorders. And so over time, they have increased their capacity to do those things, and they're able to screen in an ongoing way. Day to day, our staff are screening families, and they're looking for things like distress and discomfort. They're looking for these more subtle changes that can happen in families that would indicate, that they need something more than they're getting. And so it's really been a great experience. I get a lot of staff that come up to me regularly now who say, this dad was pacing in his room, or this mom was fidgeting more than she usually does. And so there's all of these things that the staff are noticing now as they're screening, so to speak, the families that they're taking care of each day. And I think that's really a powerful idea. If we rely on mental health professionals to do this work, then it's just never going to get done because there will never be enough of us. But we really need to expand the capacity of our units to do this. So who's going to administer the screens? This is a bit of a game of hot potato, a little bit, I think. Who's going to take the extra workload to do this? Well, there's a few I think that we can consider. Social work is, I think, an intuitive one, a group to go to. They're already completing an admission assessment in most cases. They have mental health training, but the drawback for them is that they're already very, very busy. I think this is a group that's heavily underutilized, by the way. I think they get stuck doing a lot of case management and liaison work when they could be doing other things. But regardless of that, they are very busy. Nurses, nurse case managers, bedside nurses, they have certainly a lot of familiarity with families. They're frequently at bedside. The drawback there again is that they're already very busy too. And then mental health providers can certainly help with this too. They're already trained to administer and score these measures. But the drawback there is just their availability. If they are present at all, their time may be really limited in the NICU. And so no perfect answer here, but really want you to keep in mind that a frontline staff person probably needs to be the person to administer the screen. And the more we can integrate that into existing clinical activities, the better this will seem to go. So how to follow up on screenings that we give. I really want to be clear. The first thing that I listed here, because of its importance, is that we be sure and report results of all screenings. Sometimes there's the thought that we just need to report to parents positive screening results. But think about what we're asking them to do. We're asking these very busy parents, very preoccupied parents, to take time to really share with us some very personal and very sensitive details from their lives. And I think we owe it to them to follow up on all screenings that we do. So it may not need to happen the next day if the screenings were all negative, but we do need to have some protocols in place to ensure that every parent who completes a screening is having some feedback on results. So beyond that, of course, we want to certainly prioritize any positive screens and make sure that we're following up with parents on that and allowing them to ask questions about results. And then a positive screen is typically going to trigger a secondary screen, which would be conducted by a mental health professional, someone with mental health training. And that's going to take the form of a semi-structured interview, certainly would be additional observation, perhaps some diagnostic assessments. And then making sure that we have, as part of this follow-up protocol, a way to connect parents with appropriate treatment. And those resources should not only include mental health services, but it should be a whole range of community programs that might be available in your area. These could be transportation, financial aid, housing, legal counsel supports, all depending on the need of the parent and the results of the screening. And so it's a good idea to have all of this on hand. We don't want to be trying to create this as it's needed, but make sure that it's there and available for anyone to give to families. So back to this PPPHM model that we talked about earlier. These three risk tiers of this model correspond also to how we can allocate psychosocial services and why using, I think, a risk screener like the PAT NICU can help us. So think about that bottom tier, that universal tier, where everyone gets a certain amount of psychosocial supports, social work support, perhaps support groups that are available. These are the things that everyone gets regardless of screening results, regardless of time in the NICU. And then as we move up to that second tier, the targeted tier, this would be for those who are experiencing additional distress, who have a positive screen, and who need to receive additional services and supports. And perhaps this is where a behavioral health consult is triggered, additional screening would be indicated, and we increase the number of supports and services that are available. And then at the top clinical tier of this model, these are parents with persistent, more serious symptoms, multiple risk factors, and receive the highest level of services that we can provide. So be individuals who need intensive individual therapy, medication management, and so forth. Okay, so how do you document all of this? You know, for years as psychologists, we've been battling this question, and I'm not sure I have the complete answer today, but it's very tricky to understand what to document where, especially when most of everything is documented in the baby's chart. So in terms of documenting a screening process, we need to document these three things at least in the baby's chart: that the screening has been completed, that the results have been communicated to the parent or parents, and that resources have been given. So we really, as a general rule, need to not include highly sensitive and very specific details about parents' social emotional functioning and histories. If the parent has their own patient record, then we're able to document additional details about the screening results there. But that seems to be a minority of cases where that's available. I know that in many NICUs throughout the country, if the parent is going to benefit from more intensive services, so if there is a positive screen and they're in that targeted or clinical area, then they will proceed with opening up a patient record for the parent themselves. And so I think that can allow us to document at a different level. But if we're just documenting in the baby's chart, we need to be careful with how much detail we actually put in. So what are some of the barriers to doing all of this? Well, there are a number, unfortunately. I think one is all of this seen as a competing priority by the staff. And I think we minimize this if we do our due diligence in training the staff and really setting it up in the right way. But even then, it can be seen as just another thing to do. We've got these other research projects, we've got quality improvement initiatives, and this is just another thing that we have to do. That's certainly a barrier to doing all of this, and it's going to lead to really an unsustainable protocol. Larger units just have a more difficult time doing the training and incorporating the screening. Just there's more moving parts, there's more people to train, there's more people to make sure are invested in the process. There's certainly language and cultural barriers that abound. Even though for a lot of these measures we have various languages that they've been translated into, we still have a lot of cultural barriers that aren't addressed just by translating a measure from English into Spanish. And so those certainly are barriers to screening parents. There can be a lot of confusion about what things mean and how parents with other cultural backgrounds understand what we're asking for. It can be really difficult to establish contact with parents. You know, I tell my staff in our NICU that I've probably spent 2 of my 14 years in the NICU wandering the halls, looking for parents, right? Trying to connect with them, and our schedule's just not aligning. It's difficult to get in contact with parents, and so that remains a real barrier to any of these efforts. And then if we utilize a real passive approach to screening, then I think that is going to, in the end, be a detriment to any of these screening efforts. For example, leaving the materials at the baby's bedside, or not doing follow-up calls, or anything like that that's more of a passive approach, just probably isn't going to result in good screening efforts. So in summary, let me just highlight a few things here that we've talked about. Psychosocial screening of all parents, universal screening should be the standard in our NICUs. Using frontline staff to conduct the screening is very important. If we rely on research assistants or people who aren't on the unit full-time, we just risk missing people and not having a sustainable protocol. Screening should really take place throughout the infant's NICU hospitalization, and not just at the beginning, not just at the end, but in an ongoing way. We need a broad array of evidence-based and well-validated assessment techniques. This should not just be the EPDS or just one measure, but this needs to be an array of assessment and screening techniques that should be used. Positive screens need to be followed up with a secondary screen, and that needs to be done fairly expeditiously, so we can identify any urgent or psychiatric concerns that might be present, and ensuring that there are protocols in place for responding to these positive screens. A plan goes a long way in being able to connect people with services that they need in a timely manner. And I guess the other thing that I'll just mention that I failed to mention before is, the absence of fathers in a lot of this research and these efforts. A lot of screening happens with moms, very little happens with fathers, and we really need to understand that process better and those barriers better, so we can adequately screen and care for fathers as well. Okay, we're going to kind of shift gears a little bit as we come to an end here, and hopefully we'll have some time for discussion at the end. I really want to talk about what I think is really the next frontier in assessing and delivering mental health care. And it's a technology-driven system, one that incorporates online self-assessments, one that incorporates digital tracking and passive symptom tracking processes, and interventions that are delivered via mobile technologies. Now, everything that I'm going to share with you is already available. So these may not be widely available, but they are all available at some level now. And so I think, again, consider some of what I'm going to present to you and consider what you could begin to incorporate into your units in terms of screening and delivering interventions. I'm going to do that through a hypothetical case example. And I'm going to go through a lot of different things that could be done. And so I just wanted to really illustrate what could be done at the moment in terms of using technology. Okay, so let's take Miss Jones, who's a 25-year-old mother whose 30-week-old baby was just admitted to the NICU. She's given a tablet to complete psychosocial risk screening. As she types in answers to questions about her emotional well-being, an app runs in the background and collects information on how long it takes to complete the questionnaire and number of corrections she makes to her answers. This information is then fed into an algorithm that compares her data to other women in her demographic and calculates an estimate of cognitive performance. Then natural language processing algorithms, these are really cool, by the way, they survey the content of her answers to determine if any psychosocial issues are mentioned. So right off the bat, you see how we can reduce the burden on staff by using these algorithms that help us identify themes and critical items. This information then alerts the NICU team, anyone on the team, to any risks for postpartum depression or anxiety that need to be addressed. Ms. Jones is then asked to complete a few more mental health screenings. On the smart tablet, a computer avatar pops up, asks Ms. Jones a series of routine questions about her sleep, appetite, concentration, and positive aspects of her day, collecting a 2-minute vocal sample. The vocal sample will be used as both a baseline measure of her vocal expression and as a means of screening for depression and anxiety. So the data that you can get from these vocal samples is really varied. So it's not just the content of answers, but it's also data on language generally, prosody, fluency, latency, hesitations, all these things that are really important as we're trying to predict and identify mental health symptoms. Dr. Smith then reviews the history and social emotional data, sees that Ms. Jones is at increased risk for developing postpartum depression. Dr. Smith, based on clinical judgment and recommendations generated from the assessment app, gives Ms. Jones a prevention plan that includes daily physical activity, suggestions for increasing social support, and strategies for improving sleep. Additionally, Dr. Smith helps Ms. Jones download an in-home wellness check app that contains the same tools as the assessment app used for the intake screening. This app also collects continuous passive data on physical activity from the phone's accelerometer and GPS, uses the GPS to measure Ms. Jones' activity space, which is an analog of social activity, measures social connectedness gleaned from information on the number of texts she sent, calls that she made, and number of texts and calls that she ignored. So there's more. To measure sleep quality as well as stress levels, Dr. Smith recommends that Ms. Jones use one of the commonly available smartwatches. These devices can estimate level of emotional stress through skin conductance and heart rate. As a bit of an aside, the other day I was in a meeting and someone had to stand up and present something, and she stood up and she said, my smartwatch just told me to breathe. She was obviously very stressed and very anxious about standing up to speak, and her watch picked up on that and it told her to breathe, gave her an instant intervention. So these the wearable watches, the smart watches, can also estimate sleep, even the stages of sleep, on the basis of heart rate, oxygenation, and motion detection. In case Ms. Jones doesn't have the income to purchase the device, The app she downloaded on her phone can estimate sleep quality from ambient sound, provided the phone is on and near her while she sleeps. Okay, and then just a few more points here. Once a week, Ms. Jones is prompted to complete her in-home wellness check by her app. Throughout the week, data is collected through her app and health band on her physical activity, social activity, and sleep. And the data is monitored for changes that might suggest the risk for depression. When risk is detected, suggestions for brief therapeutic techniques are given to Ms. Jones through the app. The weekly wellness check includes information on vocal analytics and a brief self-reported based mood thermometer. As in the intake app, Ms. Jones is asked questions about her week in order to collect vocal data and is asked to send a brief email to the NICU psychologist or social worker. And then if more extensive intervention is given, the data from the app and health band will serve as a means for measuring symptom improvement on a continuous basis. So again, all of this is available, and it's really exciting, I think, to think about how we could use more of this in the NICU to not only more continuously and more effectively screen, but also intervene and reduce, I think, the burden on the NICU team itself. So what are some benefits of this technologically driven mental health assessment treatment approach? Well, it certainly standardizes the delivery of materials, which is a problem sometimes. Everybody gets the same thing. Everybody is delivered the same screening and therapeutic materials. Although the privacy of reporting symptoms is maybe not unique to this kind of approach, we know that when people are allowed to report in private, that they tend to report more candidly and honestly. Certainly reduces the burden on NICU staff and is a convenient, feasible, and really a comfortable way to provide assessment treatment. There's so many of these things already available and accessible to people. You know, we're used to using these devices, and I think that that's really very helpful. There are a lot of these wearable devices, and I just read that Levi's company actually has produced a wearable jean jacket where you can touch the sleeve and play music and take calls and texts and things like that through the jacket. So I think we're just scratching the surface in terms of what we can do and what the future holds for this. This is really the next step, I think, in the evolution of mental health assessment and treatment efforts. So I'm going to leave you with that, and hopefully we have a few minutes for some discussion. So thank you very much for sticking it out with me.
Okay, guys, great. Thank you so much, Dr. Lassen. I'm not going to be able to get to all the questions that are in the chat. I am grateful to a lot of audience participation in that avenue, but I can get to a couple on behalf of the team. So one recently is from Linda. It says, excellent talk. Thank you for your expertise. You mentioned how it's important for frontline staff to do the screenings. There are maternity and NICU case management programs offered by many health plans. These case managers build relationships with families, address issues, and help connect people with external resources. What are your thoughts about these case managers performing screenings? And are there separate billing codes for these screenings?
Yeah, good question. So there are some separate billing codes for assessment. Some of these measures don't meet that threshold for using those billing codes. And so we can use billing codes that we already use, health and behavior codes and things like that to cover our services as psychologists. I think there are a whole host of other staff resources that we can leverage. Some of those that you mentioned are certainly after discharge, and some are available during the NICU hospitalization itself. But yeah, I think it's going to differ perhaps from unit to unit. But I think what we need to keep in mind is making sure that we're not utilizing people that aren't readily available on a fairly consistent basis, and who have the bandwidth to do it. And so I think if we can again fold this into regular clinical activities, then we're going to be more successful with it. But anytime creating a separate process is really dangerous work because everyone is so busy. So we really have to think about how to embed it in what's going on already, I think, to be ultimately successful.
There are several other questions, Dr. Lassen, about billing when our baby, our patient, is admitted, but we're providing services for the parents, for the mother or the father. Can you speak to any of your experience in that regard?
Yeah, so I've really gotten to know our billing department and our risk management department through all this. First of all, you're going to have to do a lot of education at your institution about this. This is so foreign to billing departments and others who typically deal with billing issues. So you're really going to have to educate them. But the health and behavior codes were originally developed for these kinds of situations where we are providing services where there's not a mental health diagnosis for the patient, but there's still value to our services, of course. And so I would really think about using H&B codes. We use a lot of family therapy codes, with or without the patient present, depending on if we're in the baby's room or if we're in a separate location. And so there are some ways to get some reimbursement for services we provide. I don't think the compensation is really good. It typically isn't with a consultation service anyway, but those are some that we've been successful with here and that I think would apply to most of your institutions. But you really need to sit down and you really have to sell your billing department and your risk management department on this, so they understand what services you're providing, and they're going to champion that for you and with you.
Yeah, that's one of the barriers is the billing piece when we're making presentations to our administrations. The other piece is the accountability of the positive screens that I've heard from several members in the chat today and in my own institutions at different times. So I was wondering if you could comment on when we are developing these screening programs in our unit, some best practices in gathering community resources when the resources aren't readily available within our institutions.
Yeah, well,
as neonatologists, that we're some of us on the call.
Yeah, I think you really need to partner with somebody with a link to the community. Social work usually has a really good finger on the pulse of that. They know what the resources are. I think you can reach out to places like Ronald McDonald House. You can reach out to your local health department, community mental health centers in your counties and areas. Those are some good folks to partner with to develop some of these resources to make sure that you have, the latest and the greatest what's available to you locally. But it's a process, and it's a moving target too in a lot of ways, because some of these programs, they come and they go, and you really have to make sure that you've got up-to-date information. I think it can also include online support groups for parents. Organizations like National Perinatal Association has done tremendous work in developing supports and resources for parents. And so, yeah, I empathize with you who don't have really a sense of what those resources are. But you got to broaden the net. You really got to bring in onto the team people who can help provide that.
Thank you so much, Dr. Lassen. There's a couple more slides. If we can move to the next slide, I'll draw everyone's attention. So those of you who are still here with us, I appreciate you for hanging out a little bit longer than the hour that we had allotted. I do ask that you fill out the survey that will come to you via email about your participation in today's campaign event, and we hope that you'll participate in our next monthly event. Here's a QR code that I'll leave here for a second. We hope that you'll visit our website for more campaign information. And then if you'll go to the next slide. If you'll hold the date for March 9th, we are going to be joining together again for the topic of mental health interventions in the NICU.